I'm Andre Fernandez. You guys know me from the course so far. I'm a clinical fellow spinal injuries. We will try to give you a basic understanding of the spine anatomy so you guys understand the why of the management behind. We will try to sort of explain you how to identify the red flag signs in any spine threatening situations, even overnight, and learn how to basically manage patients with confidence and safety on a ward-based setting. In regards to spine anatomy, so here we go. It is quite a complex set of bones. It is quite a daunting structure. I think most of you guys are familiar in some sense with the spine, the subdivision that all of you know, as in the cervical, thoracic, and lumbar, and then the sacral regions of the spine. It's a sort of a block of bones, of structures that holds the spinal cord inside, meaning the extension of the brain that's life important to manage whatever we do in our daily activities, meaning from perceiving sensation to sending orders to your muscles to walk, from everything. Everything's managed by the spine itself as an extension of the brain, and it's within the building blocks that we mentioned, the bones. It is a subset of, or specialty of medicine that is sort of on a gray area. For example, here in Portugal, I've practiced very little here, but on my orthopedic rotation in Portugal, we would take a lot of spine-related injuries and manage on them. So there's a subspecialization of orthopedics that is spinal surgery. But neurosurgery is the principal, the biggest component of it. So for example, at the Trust where I work now, we do take spinal patients, but only after we had a full plan documented by the neurosurgeon. Even if it's for conservative, for transfer, whatever it is, we do take spinal patients, but we don't operate on them under the orthopedic department. So this might vary depending on where you come from. As we said, quite a complex structure, the spinal cord. The building blocks, the vertebrae, like along the whole of the back of the body, which then holds the spinal cord. There's multiple levels, there's multiple nerve roots who sort of extend to both sides of the spine through a special canal. So the spine itself is within the foramen, within the bone on the vertebrae, and I'll show you a better picture about it in a second. And the nerves bilaterally on both sides extend out to the body. And there's, as you can see, plenty of them, loads of them. In regards to spinal fractures, there's a lot that can be said, but we're not here to classify every single subset of spinal fractures, because you can go into quite a deep into it. There's hundreds, or let's say dozens of classifications for when subsets and categories for spinal related fractures. As you can see, this one's quite an obvious one, but it's easy to understand. There's stuff from compression fractures, sort of a line across the vertebral body, as you can see there, or a wedge, which is a subset, which is this one here, sort of like a dip, a sort of a collapsed aspect of one of the borders, or more obvious ones as in burst fractures, which are more complex, sort of shattered pattern of the vertebral body. There's even more subset of fractures. The fractures can be dislocated or not dislocated. So there's a lot that can be said, and I'll show you a few more pictures. The management and the mainstay of the neurosurgical decision is based off what they know about the spine. They most of the times look at the spine as in a 3-column system, and this is quite specific, I know, but it's not important. But it's good that you know a little bit of the why behind all of this. And depending on how many columns and which column is involved, they might say, "Ooh, this is quite a bad one." But it's only for you to know that Dennis theory is sort of one of the biggest theories that relates to how spine decision making occurs, and it's all based off the complexity of the ligaments associated with the spinal bones. As you can see here, it's quite a complex structure. When we go into the subsection, the cervical spine fracture subsection, it's even a more complex one because the C-spine vertebrae is a bit different. As you can see, the C1, the C2 have a different shape, and they sort of connect on many different aspects, on many different points, with a very different type of joint. Any spine or most spine-related injuries, in specific the subset of cervical spine fractures, is associated with high impact, from road traffic collisions to contact sports. And it's definitely a life-threatening situation. There's a lot of important structures, not only on the spine, but closely related to the neck, and the nerves that origin from this cervical region are related or controlling most of the life maintaining functions, body
play with
functions.
Someone. Who you play with?
Oh, I think someone's not on mute.
Why are you so rude? Who are you playing with?
Okay, we'll give it a few seconds, guys, just while Emma mutes the rest of the participants.
You're playing on your own.
Hello, Emma.
Yeah, done it.
All right. Okay, it's just checking if you can hear me because I'm still on the presentation itself. So in regards, as I was saying, to C-spine, it's a very complex, different type of vertebrae, different type of joint. It's closely related to very important body functions or nerves that control, or regions that control very important body functions, so they can suddenly deteriorate into a high-risk situation. Just to give you a slight overlook on how complex a broken bone can be on the C-spine, depending on how the body lands, it can crack on many different sets, and it then dictates the management. You wouldn't really see the 3-point immobilization, meaning the straps, the C-collar, the blocks, or when I say straps or tape, you wouldn't really see all of this on the ward-based management. As a patient being wheeled into your ward shouldn't really be with this complex of immobilization, but I think it was important putting it here so you guys can realize how patients should be brought in from an ambulance if there's a clinical suspicion for a C-spine injury. This is done at the scene, is done by the paramedics, and in case you rotate to emergency medicine, it's good knowing the importance or a 3-point correct cervical spine immobilization. This is all to avoid further deterioration, to avoid any movement on all of the important axes of the body. There's more complex ones. There's even highly skilled operators that can do a lot on the scene. But yeah, this is how, and it should be taught and trained if you're a paramedic or let's say A&E, first care, primary care intervention sort of a healthcare professional. For management of the C-spine subset of fractures, yes, it can be always operative versus non-operative or conservative. For the operative management, we will not get into that. That's a subset of neurosurgery. But for conservatively managed C-spine fractures, you still need to immobilize them. You remember that there is loads of ligaments around that can be sprained and weakened, and a weakened sprained ligament around a broken bone, it's not a good thing because it's gonna, or it won't stabilize as we need the bone, and it won't keep the bone steady so it heals properly. So you have stuff or immobilization devices from soft, more conservative sort of immobilization devices, more like less harsh, to hard collars onto halo braces, for example. The indication for each and individual one of these goes all back to the neurosurgical decision, goes all to the complexity of the injury, to the suspicious on ligaments associated with it or not, and how stable the injury is. But this is all a neurosurgery decision that is made, and we just implement the plan. And both, or let's say the hard collar and the halo brace, are the most stable devices. So you can hardly go wrong, even if you don't know yet what the final management will be, or you're awaiting sort of investigations, MRI scans, and so you can't go wrong putting someone on a hard collar, sometimes very hard with frail patients, and then stepping down to a soft collar. It's always a good, or it's probably the best policy. There's a lot that you can do besides providing immobilization, meaning providing the device that the neurosurgery department sort of ask you to. You should think about sitting upright when possible, if there's no associated injuries, if the patient tolerates. A SALT assessment might be needed, but we'll get into that. Chest physio might be needed, provide plenty of analgesia, and then monitor the neurology according to a few charts that we have, namely the ASIA. I'll also explain that. I do have a question for the chat. I won't be able to see it, but Emma can tell me in a bit. So what do you guys think is a very common complication after spinal trauma? So if you know the answer, I'll give you 30 seconds, just type it in the chat and think about the 3 highlighted options here. Why is this important? What complication might this help with? It's a high risk feeding situation. Imagine a 95 years old plus, frail already, with some impediment and not independent, meaning dependent on carers to provide for them. And now with a new spinal injury, a cervical spine injury, and having to rest in bed and having a lot of pain along the neck with ligament sprains and all that, like it would be a high risk situation. And one of the reasons why people might die in hospital after spinal injury that's not related to spine itself, it's from aspiration and developing a serious chest infection. So next question, guys. Why do you think it's important to document neurology quite regularly? It's important to set a baseline, to know exactly how the patient stepped into the department, what's the neurology at the moment that we admit the patient to a ward, especially on the subset of frail patients that already have poor mobility or decreased sensation because of diabetic neuropathy, or let's say a very complex past medical history with a stroke, meaning there's already impairment, but on top of that, they had a spinal injury. So it's very important to document what the baseline is on admission for purposes of knowing what the patient looks like, but also to monitor any acute changes. So if you don't know what the baseline is, how can you know that the patient actually deteriorated? So the ASIA chart is a very good way of ensuring that. Depending on the concerns in the patient itself, you can do it up to, let's say, every day or every other day, or reassess every week when the patient becomes more social than medical admission. Going on to the subset of thoracolumbar fractures, I think this picture depicts it very well. And if you remember this sagittal, sort of the cross-section view of the spine, you can clearly see that this vertebra is different. It doesn't look normal. It looks cracked, burst, and it looks like portions of it are migrating backwards onto the canal. Both the cervical but also the thoracolumbar fractures are very painful. The management varies a lot, and we'll go over that, and may or not be associated with the frailty subset of groups, with degenerative spinal conditions, and so on. So this is one of the pictures that shows you how complex the classifications can get, and depending on how badly cracked the vertebral body or the spine itself is, how many columns are involved. And this is all a neurosurgical consultant-led decision. The management varies from stable injuries that we are happy with conservative management with a brace or something like that, up to very unstable ones who are blue lighted to the major neurosurgical center for operation overnight. So it varies a lot. And depending on how complex it is, or putting it on a different way, the more complex the fracture is, the more likely it will be unstable because the fragments are moving, and likely that will need some sort of intervention. The picture that I've added here, it represents a very good or it depicts very well why spinal fractures might be concerning. This is one that has a tumor on it, but as you can see, the spinal cord runs just behind the vertebral body. So anything that messes up with the spine, with the spinal cord, with the nerve going out of the spinal cord, it can compress anything around this, and it's a very tight compartment. Anything around can compress, can endanger, can put pressure on the spinal cord, which is bad. This one is specifically a tumor, but imagine same principle applies to a fragment of a bone that's broken and moving backwards, to a disc, for example, an intervertebral disc that's slipping, but the same principle. Anything that's compressing is bad. As I said, it's a neurosurgical led decision, depending on the complexity, depending on the patient itself, the neurology that we're documenting on a daily or not daily basis, and then the outcomes decided. It can go surgical, and these are just a few examples of things that neurosurgeons can do, from screws to bypass the broken bone, as you can see here, and hold the fragments that's unstable, sort of with rods and scaffolding around, or other stuff like injecting some sort of cement onto the vertebral body that's broken. There's a lot of stuff. This is just so you can be a bit more aware that there are options for surgical management. But on the ward-based management, stuff that we deal and can act on, we talk about braces. So from sort of corset style braces that embrace the thoracolumbar region to more complex hard TLSOs. And all of this is applied and implemented by the specialized trained medical professional, meaning a physiotherapist or a doctor or a nurse, who has a degree or a training on putting a TLSO appropriately, because there's a specific way you should do it. We can do a lot more than just provide a brace, as you guys know. We can give regular and should give regular analgesic. As I said before, it's a very tight compartment. There's a lot of nerves. There's a lot of reasons why the patient might be in pain, and it won't be compliant with anything that you want to do. Depending on the complexity of it, the neurosurgeons might advise that the patient should stay on a flat bed rest and be log rolled, meaning the more complex the break, let's say all of those that seem to have fragments going to the back or maybe endangering the spine, need to be bed rested, because anything that we do to the patient, if we're not bed resting, if we're allowing gravity, allowing the patient to be standing up, the fragments or the vertebral body might collapse further, and the fragments might migrate even more, compromising the spinal canal or the spinal cord. And I think I've just answered my own question. So as I said, the importance of keeping a patient bed rested is to avoid further displacement. We want to avoid exactly what's happening here. Or let's say if this little portion keeps on migrating because the gravity and the patient's not in a bed, the gravity keeps pushing the body down, the fragment will just displace here, and the spinal cord that's running through the canal might be compromised, might be pinched. And lastly, regarding this session on spinal injuries, one thing that warrants commenting on is a very specific syndrome, one of the neurosurgical emergencies that we have, which is the Cauda equina syndrome. You've definitely heard this before. On an orthopedic ward, you'll definitely had patients with suspicion of a Cauda equina syndrome. And the Cauda equina syndrome is just a neurosurgical emergency where the spinal cord, as you can see here, it's getting pinched, let's say, by anything that's external. So from a slip disc, from a broken bone, from a tumor, for some reason, the spinal cord is getting impinged at this level here, as you can see on the right-hand side. So at the level where the spinal cord sort of bifurcates as sort of the cauda, as in a tail of a horse. And there's a lot of nerves that can get impinged, a lot of things that can get compressed, and it's very painful condition and a very, very poor prognosis for the patient if it's not addressed as an emergency. So the whole goal of not missing cauda equina in scanning is avoiding people, for example, losing their strength and the ability to walk. There's a few CT scans here showing you a few good pictures of what the cauda equina might look like on a scan. For example, here, I think it's easy to spot. You can see something's not right, something's not the same when you compare with the other sections. You can see the line, and then suddenly here it pinches a little bit. So it might be pinching, it might be compromising the spinal cord. And same thing on this side. Cauda equina, you can see the little strias, as in the little filaments of spinal cord from this region here. And when you go downwards, one of the discs, maybe due to a fracture on the L5 or not, sort of is displacing backwards. So maybe compromising the spinal cord. It's a neurosurgical emergency. It's something that neurosurgeons want, or let's say when a patient goes into the emergency department and there's a suspicion for it, the neurosurgeons want to scan ASAP, either the next morning or even overnight if it's that concerning. At my trust, we don't scan, we don't have an MRI scan available overnight. So that makes us having to transfer a patient to get the MRI scan if it's that concerning. But the neurosurgeons might just say, let's wait, do it in the morning, and sometimes keep the patient ill enough on a bed rest because we don't want to make it worse. As we said before, let's keep them monitoring the neurology. If something changes acutely, then they might consider bringing the patient over overnight. And an MRI is usually the gold standard investigation that you'll see patient having, because it shows soft tissues really, really well. The red flag symptoms, meaning the signs that you should look for if you do any rotations in the emergency department, or let's say you're on the ward and someone starts complaining of back pain, but you're not really sure why, and they have some complex past medical, are these ones here. So saddle anesthesia, meaning loss of feelings around the buttocks, the anus, and the genitals, sort of as you are riding a horse on a saddle. Peripheral nerve pain down one or both legs, so back to leg pain. Bladder or even bowel incontinence, meaning not being able to control their own bladder or not realizing they pass urine or stool. And any numbness down the rest of the legs is also. So this is, as we said, an acute emergency that needs addressing. Overnight on a ward-based care, you guys need to, if it's not diagnosed, awaiting an MRI to keep the patient rested. If it's already diagnosed, it will probably be managed on the neurosurgical department, and that would be up to them. It wouldn't be something usually at these NHS trusts that we'd manage as an orthopedic department. And that's it. I think the spine is a very complex thing to address, but I think I tried to keep it very simple, even though there's a lot that can be said, a lot of concerning points or a lot of points to be made regarding the classification of spinal fractures. But I hope this gave you a good overview on what to look for, how to look for, what is actually concerning, and what you can provide the patients with besides just an immobilization device.